Okay, so bear in mind that we are live. This is very peculiar. I don't think this is a situation that any of us have ever been in before. I certainly haven't. I shall do my best to control you all. If you wish to speak, just indicate. If I don't know your name, I'll point at you somehow. There is a list. You will be able to ask as many questions as you like, but I'll be working down the list. So if you've got another question, you'll just have to wait till you come round again. Okay? So it being 10 o'clock, we will start the Health and Wellbeing overview and scrutiny. We're in County Hall, as if you didn't know, and this is very strange. So we shall start with the first item on the agenda, which is membership in terms of reference, which we all know. And then it's apologies for absence.
Apologies from Councillors Ferguson and Homer.
Okay, excellent, thank you. There's none from the floor. Then we go to the minutes of the previous meeting, which is on pages 1 and 6. And I'm looking for people to propose and second them as a true record that were there. I think Richard Dodd was. And Kath.
I was there at the... Sorry, Chair, I was there at the board, but not at the Health and Wellbeing.
I'll approve the minutes of the meetings for the overview and scrutiny held on the 6th of April 2021. As a true record.
And hopefully Les will second that.
I second that, Chair.
Excellent. Okay, well that's one awkward thing over. Then it's the disclosure of members' interests. We all know what we need to do in those circumstances, and there doesn't appear to be anyone indicating anything more. Then we're at 5, which is the forward plan, which is just a note, really. So if we're all happy that we've noted that and we understand where we're going in the next few months, be great. And then we're at the Health and Wellbeing Board minutes, and they're just a note. And then we are at the exciting bit, it's 7, which is the NHS White Paper and ICS update, and we have Sir James Mackey and Mark Adams. And if you can't see that, I guess you could move further back. Kath, if you needed to see it, I guess you could go and sit at the back of the room, so long as you put your mask on first. I've got a set of papers that are printed off, so Sir James, if you would like to kick off.
Thanks, Chair. Can I just check how this works? I've just done that a couple of times and nothing's happening. So, anyone know how the doofer works? No.
Off to a good start.
Yeah. It's always the technology that gets us, isn't it?
Are you able to just call for the next slide and do it on the laptop?
Can do, yeah. Yeah.
Thank you so much.
Okay, so I'm going to just run through with Mark what the ICS proposed legislative changes are all about. So as always, we'll run through this a bit of a sort of standard slide deck that we're using in different places, and then we'll ad-lib as much as possible and explain as much of the context and sort of texture as we can. Happy to take questions as well as we get through it. So next slide, please. So we've got a big footprint in the northeast for the ICS, and the point of that was there's a few things. One was I think over time the ICSs will become more structural and more SHA-like, and we found over time in the NHS that this sort of footprint generally serves the northeast well. We do a lot of things on these footprints, such as the medical education, doctor production system works on this footprint. A lot of the clinical networks work on this footprint, etc. But it does give us other tensions, especially around connection with place and primary care, for example, on that kind of large footprint. But next slide, please. It is very, very big ICS. It's the country's biggest. One of the problems we've got is there's a huge variation across the country, where some ICSs are about the size of Northumbria's footprint, so maybe 1 or 2 places, whereas we've got one that covers, that huge geography, 12 or 13 top tier local authorities, 70 odd PCNs, you know, et cetera, et cetera. It's a very, very big ICS. I do think at some point there'll need to be a bit of a consolidation, maybe in the autumn, where they'll some of the smaller ICSs will have to be merged or aggregated with others to give them a more reasonable size footprints to do the sort of things that they're going to be expected to do going forward. Next slide, please. And in my view, there's two main things this is all supposed to be trying to do. This is a necessary impetus to tidy up some of the confusion of the 2012 Act. The NHS, when it was reorganised in 2012, ended up with a very complicated and confusing structure. So a big part of what these legislative changes are aimed at is sorting the NHS out so it has more of a local headquarters, something like an SHA that is more able to handle local matters on behalf of national bodies and hold local NHS bodies to account. And then the other big part of the job is connecting with partners, especially the local authority system across a large footprint, and working on more strategic health improvement, population health, skills and employment, you know, those sorts of things. That's a very, very difficult set of things to manage. So structurally, they've come up with a particular way of doing that through a sort of two-board system, which I'll explain later on. There is a very big impetus now post-COVID to try and use these mechanisms to help tackle inequalities, to try and help local economies regenerate themselves, etc., as we all try and get back on our feet post-COVID, but also have more ability to hold the local NHS to account. Because our current system has basically a regional system, which is Northern and Yorkshire, which is an enormous footprint. It feels very remote. Next slide, please. We are all very much pushing this need to respect place and to have this built all on the principles of subsidiarity. And in Yorkshire, they talk about it as the primacy of place. That feels a bit confrontational at times when you say that. But what we're trying to say there is all across the country, people have effective working arrangements in local authority-based areas, and the ICS needs to work with that rather than destroy that. And there's an ongoing tension as we just try and make sure we get the balance right about what the ICS does at the more strategic level and builds on what's going on in place rather than tries to replace those things that are going on in place. And also recognising that within our ICS, the individual places are all actually quite different. So, you know, Newcastle's got a very different makeup, for example, than Northumberland or Middlesbrough or, you know, North Cumbria as well, so we've got to have a system that reflects those diverse views, the strong local working arrangements, but also comes together strategically where it's most helpful to do that. Next slide, please. The place stuff is, again, at the minute, very loose. It's very permissive. We're expecting a lot of guidance to land soon. So it'll basically just build on, we think, things like the Northumberland System Transformation Board, and North Tyneside has a Future Care Board, Newcastle has Collaborative Newcastle, you know, etc. So build on those things and become more formal over time, but not become very structural. It won't be a new entity, a new organisation. Locally, it's more going to be done through joint committees and collaborations, etc., rather than creation of new bodies. Next slide, please. Next slide. Next slide. I think we've done that. So locally, I mean, lots of colleagues will be aware of this. We've got a long-standing System Transformation Board meets tomorrow. All partners are involved in that. It's changed over time, and we've just been through a little bit of a refresh of it to make sure it's fit for the new world, but generally very strong engagement, you know, good participation, starting to gather momentum. All of this needs to work with a very effective Health and Wellbeing Board and be able to build on that. So Transformation Board will increasingly be hopefully the thing that delivers the plan agreed by the Health and Wellbeing Board. And then again, Scrutiny needs to hold us all to account to make sure that we're all delivering on those things. In some places, the role of Health and Wellbeing and Scrutiny's become a bit blurred. as well. So I think there's a need across the ICS for everybody to just be clear that there's no overlap and everybody's kind of doing things in the right places, because what we don't want this to do is just to create a load more confusion, given the confusion we had post 2012. Next slide, please. And as always with the NHS, we've got this really rapid decision-making process, parliamentary process. So we've been working, national colleagues have been working on the ICS, started off with the STP thing since 2016. So spend an awful long time in the thinking phase usually, and not very much time in the doing phase. So this legislative process looks incredibly tight, borderline, not possible, certainly not possible with as much of an opposition when it starts going through the parliamentary processes. But the idea will be that this is all legally enacted by next April, which means that there isn't much time. There's not much of an opportunity for things to be late or to be snarled up in much of a dispute. If it is late, I would fully expect us to move to some kind of shadow form where we'll mimic what's expected to happen later on. But hopefully we'll not end up in that position. Next slide, please. And again, as always, we're waiting for the guidance. The NHS loves guidance, so we'll get guidance on the guidance to be about the guidance later on at some point. The key bits really are we're supposed to be getting something imminently. It was supposed to arrive last week in terms of how the ICS flesh out some of the constitutional issues for the ICS, but importantly start the recruitment process for the ICS leadership, the chief executive of the ICS, the chair of the ICS, etc. They're supposed to be in place by the autumn. So we are now, really running that very tight to be able to do that. And that will be a key part of just giving the things some shape and feel that we're going to all kind of get our heads around a bit better. So the idea would be get to the autumn, keep people in place. Then there's a few months of starting to get the mechanisms in place, the broader team set up, the partnership board set up, et cetera, et cetera. So we hit April with something that can actually work and function. Next slide, please. So there's a bit more detail on that process. As I say, we're a bit late. So the stuff that we should have had that fleshes out a bit more of the detail of how the ICS will be constructed and the appointments processes, etc. We should have had them 2 or 3 weeks ago. We haven't yet got them. Should probably get them this week. Again, what usually happens is there's a bit of a flurry before a parliamentary recess. So there'll be a bit of a rush as we run into July. Probably get lots of documents early July. That gives us the guidance that we need, and then we'll have to crack on over summer to get things in place for the autumn. Next slide, please. And next slide, please. As I said at the beginning, there's 2 real jobs, and these things get confused all the time. It's very easy to get them confused all the time, and I think hopefully over time, when the thing is established, it will become a bit clearer. But the idea is that there'll be a unitary board of a thing called the ICS, which for all intents and purposes for us in the NHS will look and feel a bit like an SHA. Again, it'll be the regional headquarters for the North East, with a board of key people focused on NHS business, holding us to account, strategic capital decisions, clinical strategy decisions, those sorts of things, working with partners in place. And then the Health and Care Partnership Board will be the engagement mechanism where the ICS engages with mainly local authorities, but other partners across the broader footprint. Less frequently, so my guess would be that would be a sort of 3 or 4 times a year thing. It'll have some specific purposes, probably about agreeing a plan for health improvement across the ICS, but with an effort to try not to get the things confused about day-to-day NHS business versus longer-term strategic population health, inequalities, those sorts of things. And even those will largely be delivered in place with their own local dimension over time. Next slide, please. Yeah, so again, just to emphasise, the theory is that this is all based on effective place-based mechanisms, all based on the principles of subsidiarities. We're working through some of this in a live way now around financial mechanisms and you know, how people get reimbursed in organisations and systems for elective recovery of the backlog, etc. So the extent to which that's determined centrally by the S rather than either through the provider collaborative or in place-based arrangements. So we've got the opportunity to trial some of these things out this year and get the wrinkles ironed out before we go live next year. Next slide, please. And next slide. So I'll hand over to Mark.
Thanks, Jim. So, as Jim said, we are waiting for swathes of guidance to come towards us, and we hope and expect the first set of guidance will come towards us very soon, and it will start talking about the structure. But we are in a position where we have already had an ICS and an ICS way of working for some time, not as a statutory organisation, which is now what is envisaged, but as a way of working. And one of the key tasks that we will need to do as we move towards the ICS is the closing down of the clinical commissioning groups, the CCGs, and the innovation of their responsibilities into an ICS. I'm not going to go through the slide in any great depth and detail, but just to say we already have a lot of those ways of working in place. We continue to think about how it might work under a new statutory ICS organisation, but until we get the guidance, there's really not a huge amount of work that we can do on that because we are expecting that to come in the guidance. However, we do have that way of working already in place, and as Jim said, the hope and expectation is a lot of this is about building on what we've already got, not creating something absolutely brand new. Next slide, please. In terms of the national view of the world, we have already seen some glimpses of what the expectation is. We are already, as you would expect, in lots and lots of discussions, both at a regional level across North Eastern Yorkshire and nationally with colleagues about how we would manage change. The hope and expectation is, and people are starting to use this terminology, in a lot of ways from a CCG perspective, it will be a lift and shift into a new organisation covering that wide area of North Cumbria and the North East. But there is obviously a lot to be done there in terms of the statutory machinery of organisations to be shut down, the statutory machinery of a new ICS to be put in place, but also all the things that also means in terms of HR and getting our staff to the right place in the system, continued employment and all of those sorts of things. There is a discussion that's been going on for quite some time about what this means for all of the different commissioning elements, not only the elements that the clinical commissioning groups directly do, but also NHSE colleagues do some direct commissioning as well in terms of things like dentistry, pharmacy, etc. So we will need to understand how those things all to come together into a new ICS operating model. But again, until we get that guidance, and we're really keen to get that as quickly as possible, we're not going to know the exact nature of that going forward. Next slide, please. In terms of some of the discussions that have gone on with region, etc., and also some of those discussions nationally, we are all very clear about the need for collaboration. This is about collaborative working practices going forward. As I'm sure everybody is aware, the NHS has been predicated on a competitive way of working up until this time and until fairly recently. So this is about collaboration. It is about collaboratives of organisations coming together, and we will see the foundation trusts, like Jim's organisation, becoming part of provider collaboratives, working together not only locally for our public and patients, but also public and patients across the whole of the ICS. This will be about partnerships. It will be about partnerships working, and we do hope that it will build on all of the things that we've already done in terms of our working in Northumberland, where Jim's organisation, the local authority, the CCG, primary care colleagues, etc., voluntary and community sector, we already do lots of work together, and the hope and expectation is that we use that as a platform to build on. Next slide, please. I think Jim's probably covered some of these things. In terms of that place-based working, the hope and expectation is that everything that we do at an ICS level is built from place up. And in terms of the place-based working, we are clear about three core components of that work: improving population health for the people of Northumberland, improving and continuing to improve service quality in the patient's experience as they move through our services, and also continuing our paths in terms of financial sustainability. I think we're all aware just how much of a financial strain on the country the pandemic has been. It will be something that looms large in our lives, no doubt, for years to come, and the NHS will have a part to play in that in terms of financial sustainability going forward. Next slide, please. In terms of our current place-based partnership, which Jim chairs, we already have a very clear and very wide set of members to that. We have senior clinical and managerial leadership from across our place in Northumberland. We have senior and leadership from the Northumberland County Council. We've got lay members, we've got Health Watch. So we do really have already quite a wide partnership. And again, this is something that we want to build on. And this direction of travel is all about collaboration. I think we already have really well, we are really well placed in terms of our collaborative way of working, and we would continue and want to continue to develop and build on that as we go forward. Next slide, please. We have a strategic coordinating group, again with a wide range of partners, and we already have a wide range of ambitions in there about providing the best possible health for our communities in Northumberland. Just as a reminder, you know, where we are sitting today, we have some of the best health services in England across Northumberland, and working with colleagues across the ICS, we have some of the best health services generally in this area. And again, our ambition recognises the importance of the economic impact of those services, especially in light of COVID, which is a nod to our wider agenda as big providers of service, but also big employers of people. You know, we do have a duty to work with everybody in terms of things like more jobs, better jobs, climate change and all of those things. And it's just to make sure that those things aren't lost in these kind of changes. Next slide, please. In terms of the work in practice, I think everybody is aware of the effects of the pandemic, not only acutely on people, their communities and families at the moment, but also what it means in terms of the restoration of services, people waiting for appointments, people waiting for operations and to come into hospital, etc. We have a provider collaborative that is already starting to work on those things, and this direction of travel where organisations are going to be working together more collaboratively than they have under previous ways of working will all help us tackle some of those things. Again, the North East and North Cumbria are probably in a better position than most across the country because we already do very many of those things. And again, the hope and expectation is that we can continue to build on that. Again, just a note, Northumberland is best performing in the country in lots of different ways already in this respect. Next slide, please. I'm not going to go through this in any depth or detail, but what it does show and what it does indicate is as we've been coming through the pandemic and as we've been dealing with the acute phases of the pandemic, whilst we've been doing that, all of our provider organisations, whether it's organisations like gyms, it's the GPs, it's other providers of service, we have been putting in place our core services again. So we can bring people towards the services that they need. We can bring people into hospital for the operations and the therapies that we need, and we can start to catch up with where we need to be in terms of supporting people with their health and care and wellbeing needs. Next slide, please. So in summary, there is still lots to be done. As Jim has pointed out, lots to be done in what is an increasingly short time scale. But we are starting from a very good position. We're starting from a very good position from all sorts of ways in Northumberland. And our focus continues to be on place and our plans for local communities. And our hope and expectation, and I guess our ask, is that we all continue to collaborate in a way that we've done for very many years, and especially throughout COVID, in order to be able to deliver this. So thank you, Chair. Very happy to answer questions.
Thanks for that. Questions, anybody? Councillor Hill, Councillor Nesbitt.
Thank you. So basically, I know the BMA have raised concerns about this, and they've talked about the lack of clarity. Seeing all this, there's inevitably a lot of jargon and talk about loose aims. I mean, put simply, if a resident was to say to me, and I do get weekly complaints about patient experience, and this isn't experience from individual practitioners, it's not even an issue, seems mainly about funding, it's a systems failure. So the complaints that I get are how difficult it is to book a doctor's appointment, travelling between different hospitals and to get services. So it does seem to be major systems failings going on. So if a resident was saying to me, I hear they're getting rid of the CCGs, is that going to make things better? Patient experience, our system's going to be better? And what could I say to convince them that it would be an improvement?
So the idea over time would be that the transformation board would deal with those things. So the individual institutions will still be responsible. So if it's an issue where we're moving people around and it's a hassle for people, we should just know about that directly and deal with it. If it's a broader system thing about how things need to be more joined up and more coordinated, I think that's much more of a place-based thing rather than an ICS thing. So I think that would be really helpful to know what those issues are, Georgina, and we will take them into transformation board discussions and get partners to work on them together. It is happening all the time anyway as well now, especially post-COVID, in terms of recovery and, access to primary care is very pressured. GPs are very, very pressured at the moment, but that will be kind of core business of the local place system.
Just a question really on all this that's going on. Is the unions involved in this?
They are, yeah. So it largely affects Mark's staff in terms of transfer of employment and those sorts of things. They've been very much involved nationally. And then Mark, I don't know if you want to pick up how that works from a local perspective.
So thanks, Jim. They are very involved nationally. We're tied into that work. Increasingly, we're being involved more locally about that. We are somewhat dependent on the guidance because we're waiting for guidance in a number of different areas. One is about the direction of travel for the ICS and the design, but there's a very key piece of guidance that we're waiting for in terms of HR and what that means for staff at all levels in the CCGs. I think once that guidance comes towards us, we'll be much more locally involved in terms of not only our staff, but also with trades unions as well.
Thank you. I think there needs to be more of a joined up approach to services because sometimes, following on what Councillor Hill said, you get complaints from residents where they maybe have to visit 2 or 3 different hospitals 2 or 3 days running, and it's if that could be more coordinated because again it'll be a saving financially for yourselves but as well for residents, and it's making sure appointments at an appropriate time for travelling because often they're travelling either early morning appointments or late night appointments, and they don't mind going to do the services, but it's a more coordinated and joined up approach.
Yeah, absolutely. So we've been within Northumbria focusing on that under the Reducing Miles Travelled initiative, which we've reduced miles travelled by about 2.5 million miles since the start of lockdown originally. But it is still an issue across organisation, and we do really need to be dealing with through the transformation board and other mechanisms.
Could I just ask, at the very beginning of the slides, you talked about the ICS and the need for mergers. Mm-hmm. Could they just not get this right in the first place, rather than create stuff and then realise that there's too many of them? Has there been no thought put into that?
Yeah, there've been discussions and arguments, as you can imagine, Jeff, over time. I think to be fair to national colleagues on this, they wanted to try and avoid a very centrally determined sort of plan created in London that's imposed on local systems, because we always reject that when they do that. I think my personal view would be we could have been a bit more precise, because the range now between the ICSs and footprint is, you're going from really quite small Northumberland size ICSs to a huge, northeast, a region, which makes the whole consistency of operating really difficult. So I think it's a fair criticism, but national colleagues took the view, understandably, that given the 2012 process was rightly criticised as being very top-down and very little local engagement. They were trying to allow more local engagement in this, and there's probably somewhere in between the two that we need to try and settle on. So I do think there'll be, over the next few months, there are discussions in other parts of the country about maybe these two ICSs should be a single ICS rather than separate ICSs.
And if there's any dispute, will government decide, or will you just have to slug it out?
NHS England are working through that, as my understanding, in places where there's a need probably for people to come together and try and reach agreement on doing that. It's not affecting us, so we're not, you know, there was a bit of a concern that we might end up in a much larger footprint, or even, again, there were discussions last year about whether we needed to break up and have smaller footprints. We decided at the time that the northeast footprint is still important. It's one of the few places in England that has an actual identity as a region, so there is benefit in working together. But that only works if we get the place and then the kind of the bit in between working appropriately. So the ICP level, apologies for the jargon again, but if you think of broadly combined authority footprints, we need those levels of interactions to work well within our ICS, given it's so big.
Excellent. Anyone else for any more? Or sorry, yes. Forgive me, could you just say who you are?
You're all right, Jeff. It's Claire Riley. So it's just
Right.
following up on Councillor Hill and Councillor Hunter's comments. If they want to send through some details through to me, I'm sure they've still got my contact details. We'll make sure that we send them through into the System Transformation Board. But likewise for all of the councillors, if there are some challenges that they wish to challenge the System Transformation Board with, just send them through and we'll make sure they feed through the system.
And just to add to that briefly, Jeff, there's very little benefit of COVID because it's been an awful 15 months or so, but one of the things that it has allowed us to do is to take individual cases and say, well, look, 2 years ago we didn't use technology for this, now we can. So there's no need for that person to do a 3-hour journey. Let's just try and apply specific tailored solutions to people. So as Claire said, if we can have the specifics, there might be something we can do that 2 years ago we thought wasn't possible, but it might be now.
Councillor Dodd.
Yeah, I feel sorry for anybody new and even old who's turned up to this. Jim mentioned jargon there. I think it's becoming excessive and a lot of people will not be able to follow it. It'll be like sitting in a different country listening to a different language. And I think that at some point we're going to have to address this sort of, I mean, we all understand an ICS now, but there's a lot of things that people just will not understand. And I just feel that time will heal it, but it's maybe out of control.
We did get sent a jargon busting thing around, Richard.
Yeah,
did he not print it off?
Print it off? No.
Right then, sorry Jim, we're just...
If I question you on everything, you'll know what they are.
No,
No.
but I've got a piece of paper that I can look at. But anyway, there we go. So anyone else want to ask questions about what was talked about the ICS? Councillor Bowman.
Thank you, Chair. Can I ask about consultation with the public? Are you going to reach out to the public? Mine is the jargon, as it were, and liaise with the public about the plans ahead. Is that in the timeline as well? Thank you.
So on the ICS change, my understanding is that was all sorted out nationally and there isn't a need for formal consultation. Claire, is that right?
Yeah, that's right. So the consultation is really around services that are changing and technically services aren't. However, about 18 months to 2 years ago, the region did do some engagement across the public and Northumberland were included in that. Obviously, COVID has prevented us from doing any further engagement with our partners across the region, but it is on the agenda to go back out to work with Health Watch, our partners as well, and just make sure that we are listening to the public. But the emphasis really is around they're not service changes. We're not changing hospitals in that way or anything like that. Therefore, from a consultation point of view, it's a bit different.
But just to add to that, you should expect us, and you need to hold us to account on an annual basis, having a public face to our combined plan for Northumberland, coming out of the System Transformation Board, and hold us to account on delivery and on all that. And Councillor Dodd's points are well made about NHS jargon. I always apply the "can I explain this to me mum" test. So when I go to see my mum on a Sunday morning, she couldn't care less about an ICS. She wants to know she's going to get seen when she needs to get seen. So we've got to work increasingly on how we create a public face that explains what we're trying to do across health and care in the area, and then takes concerns back and are held to account from a performance perspective and accountability perspective.
Okay, fair enough. But we do take on Councillor Dodd's issue about acronyms and jargon. But there is a sheet that has been issued. Perhaps I'll have a test at the next. Right, that's a good idea. At the next scrutiny, there'll be 10 questions about the jargon. Anyway, thank you, Jim and Mark, and we appreciate that. And we shall move on to the COVID update, but I guess that we don't need you anymore if you've got better things to do. Excellent. Thank you very much for coming. COVID update.
Thank you very much. So can we just go straight to the next slide, please? Great. So this graph is looking at the trends in case rates across the 7 local authorities in the north of the northeast. And what this is showing is that for all of those local authorities, the case rates have started to rise over the last couple of weeks. And actually Northumberland, North Tyneside and Newcastle are all highlighted nationally as areas with rapidly increasing rates. And actually in Northumberland, the rates have increased nearly 5-fold over the course of a few days between the 3rd and the 9th of June. So they really are escalating quite quickly. And that pretty much reflects what's happening in other regions of the country. Some regions have cases which are escalating at a higher rate than others. The Northwest in particular is seeing a very marked increase in rates. Next slide. So this is what the dashboard was looking like yesterday. So just sort of giving you a bit of a comparison. In the 7 days up to the 12th of June, we were averaging 53 cases a day, but that's compared to 3 cases a day on the 23rd of May. So that's gone up quite a lot in a matter of 3 weeks. And in fact, they've doubled in the last week. So still on an upward trajectory. But if you just hold that pattern of spread in the map on the bottom left-hand side, in your mind, because the next slide shows where we were in January. So this is the first week of January, and during that week we had nearly 1,200 cases in that particular week. The case rate was over 3 times what it is at the moment, and you can see that that map looks very different to what it does at the moment. So I think, the increases that we're seeing at the moment are a cause for concern, but not necessarily a cause for panic. So why are the cases increasing? Well, a number of reasons for that. So we've obviously got the new, well, it's not new now actually, but the Delta variant, which is what was called the Indian variant, that is, it is significantly more transmissible. So we're talking between 40% and 60% more transmissible. So more people will be infected from a single case. And actually what we're seeing locally is that, particularly within households, if one member of the household becomes infected with this particular variant, then actually the vast majority of other people in the household will become cases as well over a period of time. The other the other contribution to the increase is a change in policy around testing. So we're now testing through PCR tests all close contacts of cases, irrespective of which variant they are. And of course, the more testing you do, the more cases you find. And then we're also now seeing the impact of both the easing of restrictions on the 17th of May, but also the impact of half term. So in terms of the sort of the proportion of cases that are coming back as the Indian variant or the Delta variant across the northeast, over 80% of cases are coming back, or those cases that have been sequenced are coming back as the Delta variant. So it is very much the dominant strain that's circulating at the moment. Actually, in Northumberland, it's probably higher than that, over 90%. And the ONS, so the Office of National Statistics, does regular infection surveillance exercises, and what they're showing is that the prevalence, so that's the proportion of people who are infected at any one time in the community, has increased from 1 in 1,120 in that third week of May to 1 in 560 in the week ending the 5th of June. But there is quite a bit of variation. And then the other thing that's being reported is a possible increase in the severity of disease. So there's some initial data suggesting that the risk of admission with the Delta variant is slightly higher, but actually that, you know, it's based on relatively small numbers, so that's still very much under investigation. But locally, what we're seeing is that about 3 in every 100 PCR tests are coming back as positive. It was much lower than that, but also we're seeing that nearly half of the cases that we're coming across are asymptomatic. So this is a graph looking at cases by age group, and the one that sticks out is that purple one, which is increasing very rapidly at the end there, and that is people under the age of 25. And this surge in transmission is very much being driven by younger people. So we've got very high rates in 17 and 18-year-olds, and we also have very high rates in 19 to 24-year-olds. And actually, people between the ages of 10 and 29 are making up about 60% of our cases. But I think the good news is that actually, if you look at the red and the orange lines at the bottom there, which are basically people over the age of 60, we're seeing a slight increase in cases, but nothing like the increase that we're seeing in young people. And of course, that's really good news, because those are the people who are most likely to end up in hospital with severe disease. So I thought I'd just talk about the sort of 4 national tests and the roadmap, and these are really orientated around the vaccination programme, reducing hospital admissions and deaths, avoiding a situation where the NHS is overwhelmed, and a sort of dynamic risk assessment of the new variants which are circulating at any one time. So I'm not going to talk about vaccination because we've got a separate presentation on that. But if we go on to the next slide, obviously that second test is around the impact on or reducing hospital admissions in deaths. And we now have really good real-time data from from real life rather than from trials, which demonstrates that the vaccines which we're using at the moment are really effective, particularly after having 2 doses, at reducing symptomatic disease and admissions. And actually the Pfizer vaccine, which is the one that we've got most experience of because more people have had 2 doses of the Pfizer vaccine, is incredibly effective at reducing deaths. And actually nationally, only a minority of patients in hospital because of COVID have had 2 doses. The majority of patients in hospital with COVID either haven't been vaccinated at all or have only had 1 dose. Locally, the numbers have been really low since the middle of March. We've had a very small number of deaths since early April. When you compare that with January, when we were seeing in some weeks 6 deaths a day, you know, we are in a much better position than we were back at the beginning of the year. But vaccination isn't breaking that link between hospital admissions and deaths entirely. Next slide. So, as I said, admissions are much lower. Nationally, the NHS is reporting to us that patients are much younger, and actually when you look now at the proportion of patients over and under 65 compared to what that proportion looked like back in January, now we're seeing that the majority of patients admitted with COVID are under 65, whereas obviously back in January the majority of patients were older. So they're younger, they need less critical care, they're less likely to die. So actually, you know, much less of a burden on the NHS. But I think the issue is that the NHS is really busy. It's really busy trying to recover from COVID, and actually both the Trust and primary care are just generally reporting that the people wanting to access services has increased, and it's you know, there's a lot of work going on to try and unravel what that might be attributed to. What we're seeing in the Northwest is that cases have increased by 64% in a week, and admissions have increased by 61% in a week. And actually, if we see that doubling of case rates and admissions over a sustained period of time, that does become unsustainable in a very short period of time. Next slide. And then the last test is about a risk assessment of the new variants of concern which are circulating. And what this slide is showing is the proportion of cases which are now coming back as that new, the Delta variant, so the Indian variant. So that purple section at the end is the increase in the proportion of sequenced samples which are coming back as the Delta variant. So you can see that that is really dominating the cases across the country, and that's what is contributing to the increasing case rates. So in terms of key messages, as always, we just need to keep continuing to proceed with caution, and I think most directors of public health will be absolutely behind the decision to delay that move into step 4 for another few weeks. That just gives us a bit more time to vaccinate, well, give people 1 dose, those people who haven't had 1 dose, and also to vaccinate, get a second vaccine into people who have only had 1 dose, because actually people need those 2 doses to get as complete protection as we can. And then I think we need to use every contact that we have with the public to share those simple messages, because it is that hands, face, space, fresh air behaviours. Those are the things that prevent transmission. You know, vaccination is fantastic, but we still need to do all of those other things as well. And I think actually taking up that vaccination offer is really important. So I'll now hand over to Rachel, who is going to talk about the vaccination programme in Northumberland.
Great, thank you very much. My name is Rachel Mitcheson, Service Director for Transformation and Integrated Care, and I've been leading on the vaccination programme for the CCG and the local authority. Next slide. So, story so far. So we actually started the vaccination programme in the United Kingdom on the 8th of December, and on the 15th of December we vaccinated our very first person in Northumberland. We're using 3 types of vaccine, which is Pfizer, AstraZeneca and Moderna. And to date, as of yesterday, we have vaccinated 399,180 residents in Northumberland. We have about 2,000 staff and volunteers helping us in our county doing this work. And on one day, which happened to be the 20th of March, our record number of vaccines in a day was 7,534 doses. 83% of our population now have a first dose, and we have 19 vaccination sites across Northumberland and 1 roving model. So we are trying very hard not to leave anybody behind. Next slide, please. So this just a map really showing that we have 10 primary care sites delivering the vaccine. We have 7 community pharmacies. The hospital hub at Wansbeck Hospital was in place for staff. We've got a vaccination centre in Hexham and the roving vaccination unit. The primary care and the hospital hub used a sort of local call and recall process to get people in, and the community pharmacies and the Hexham site used the national booking system, so we have variation on all options available. Next slide, please. So these are just the priority groups that you'll be aware of. So from phase 1 was everyone over 50, which included all those clinically vulnerable and those at risk, which are part of the normal sort of flu cohorts that we vaccinate. They've all been offered a first dose, and that deadline was met by the 15th of April, but this is an evergreen offer, so if anybody comes forward and hasn't been vaccinated, they'll obviously still be vaccinated. Phase 2 we are in progress with at the minute, and currently has been extended to all those aged 25 and over, and the target to have offered everybody a vaccine of first doses by the 18th of July, which we are on target at the minute to achieve. Next slide, please. So this just shows really a graph of the different cohorts of the first doses across the cohorts within that last slide that I showed you. Next slide, please. That was the first doses. This is second doses. So this is a slightly different picture, just because when we started out with Pfizer, we vaccinated within 3 weeks, and then the guidance changed, and so there was a gap before we could vaccinate the second doses because it was pushed back to 12 weeks. And then you can see where the red arrow is. That was the next change, because the cohorts have been come forward again from 12 to 8 weeks. But that shows where we are with our second doses. Next slide, please. Really delighted to be able to tell members of the committee that Northumberland has the highest percentage uptake of first doses at 83.4% of any upper tier local authority area in England, which is out of 150. So we are really performing very, very well. Next slide, please. So just a bit of a breakdown of that latest position. So I've mentioned the overall number of residents that have been vaccinated, and then they've got a breakdown there of 227,884 on first doses and 171,296 on second doses. And care homes obviously was a very big priority area for us to vaccinate, and so you can see a breakdown there within the older and younger care homes of both residents and staff, and again really high percentage uptake within those areas. Next slide, please. Social care staff, total number reported to be vaccinated with 1 dose and then 2 doses from within the independent CQC registered homes and domiciliary providers. This is taken from the capacity tracker, so some of this data does fluctuate, but again shows a really positive coverage from our social care staff. Next slide, please. Obviously want to mention the hospital hub, which Northumbria ran to deliver vaccinations for all health and social care staff. They operated 2 hubs, both at Wansbeck and at North Tyneside. It was a really big multi-agency collaboration in order to identify the right staff and bring them forward to be vaccinated. And they did a brilliant 33,492 doses. And they're continuing to do mop-ups as people come forward or circumstances change, so really good. So vaccination's been used in the UK, so this is just a reminder of the within cohorts 1 to 9, following the guidance, we used a mixture of the Pfizer, BioNTech and AstraZeneca vaccine. We had JCVI advised use of alternative vaccine, 2 AstraZeneca for cohorts 10 to 12, which are those under 40, and that was due to a potential risk of blood clotting, which is very, very small, which is stated there, but there was a change at that time. Pfizer and AstraZeneca vaccines have been used in primary care and community pharmacies and in the hospital hub, and Moderna has been used in a small quantity within some of the community pharmacies. Janssen vaccine has been approved and is due later out in the year, and Valneva and Novavax products are currently being assessed, so we may have more vaccines still to come. Next slide, please. We have had in place a Northumberland Vaccine Equity Board, which has been working with CCG and the Public Health and the local authority just to make sure that we don't miss out any priority groups such as BAME communities, Gypsy Roma travellers, learning disabilities, people with mental health problems, and social economic deprivation. So we've looked at rurality, travel time, and looked at how we can get out to those communities, part of which has been using our roving model, which I will come on to next, I think, yes. So our primary care networks have led a model of a mobile vaccine service to reach our remote and isolated communities. It's been really, really positive. So we launched in Bellingham in early April. We've had some really good partnership working with the Northumberland Fire and Rescue Service, who have been able to use their buildings to sort of pop up clinics across the county. We've also visited homeless shelters and independent residential settings. We have also visited some workplaces. So we had really big success at Egger Factory in Hexham and another company, RPC, I don't know what that stands for, sorry, in Haltwhistle. And that's been really well received, where the van was able to vaccinate people while they were at work. And more recently, we assisted in North Tyneside when we requested a surge in vaccination as part of the rising cases of the Delta variant. The roving vaccination was sent in and did a huge amount of vaccines. It's a really successful model. So why, oh no, there's a bit more on the roving model. So yeah, very, very well received. I have to say the public really loved it. It was brilliant to see farmers whizzing down on their quad bikes to Bellingham because they actually were struggling at that time to get vaccinated and leave their sheep due to lambing. So it's been really, really interesting who have been attracted to that model, but I think certainly something we'd like to look at going forward as we probably continue to do vaccines. So why have we been so successful? We've had really incredible engagement across the whole system. It's been coordinated through CCG and through the local authority. I have to say primary care have been absolutely amazing. This has been additional work for them. They have worked in clusters, which they have not done before, and it has been an amazing sustained effort from them, and they have remained enthusiastic and been just fabulous to work with throughout. We've had good system leadership from, so another little acronym here, from SVOC, which has been basically the system vaccination centre. So Newcastle hospitals have run that and have had regular meetings across the system, and that has been hugely helpful as the programme has changed enormously from start to finish. So good communication with stakeholders, and really generally the public support has been very high. Biggest challenge has been very command and control, and that has made it quite difficult because we have had all the responsibility but none of the control, and that's been quite difficult. I think sometimes we have heard on local media first or national media about a course correction, which has been quite frustrating at times, but due to our ability to communicate, we've been able to get the messages out really fast. The supply chain at times has been unpredictable and has been very pushed to primary care, which has made it very difficult for them to plan and get people in for appointments. It's been very nationally mandated decisions, which hasn't necessarily always reflected the local interpretation and flexibility. There's been multiple routes for vaccines, and that's caused some confusion for people getting letters, but wondering if GPs were going to call them, and that has caused some confusion along the way. And really the sheer size and scale of the programme, being the biggest vaccination programme in the NHS history, has been part of the significant challenge of this. Next steps, because we have to keep going, we are working on a new target to have everybody vaccinated by the 18th of July for their first doses. We continue to bring forward the second doses for those over 40. Promoting importance of second dose uptake has been really, really important as some people have lost some confidence, particularly with the issues around the blood clotting. And it's just so important that we protect people. And there is always clinical people on hand at all sites to take patients and people's questions. Maximum uptake for cohort penetration across all the priority groups, including revisiting those that have previously refused. Collaborative and cooperate across delivery models between our primary care and pharmacy and the vaccination centres, as it's important we all work together. And we need to look ahead to the future and what phase 3 might look like, as we obviously will be preparing to vaccinate for flu, which is currently done at a practice level in primary care. But we are aware that there will be a booster programme, although we're not entirely sure who that'll be for. We think it might be for the over 50s, and we think it might also include the vaccination for the 12 to 17-year-olds. But we are just awaiting national information for how that will be run. And that is all I'm going to say. Is there any questions for myself or Liz?
What we have is Councillor Dodd, Councillor Lowe, Councillor Hill, and the gentleman I can only see vaguely. So we'll start with Councillor Dodd.
Yeah, very briefly, we're going to reach a stage where we'll have vaccinated everybody who wants to have it. What are we going to do with the ones that don't want to have it? Because obviously that is going to be the critical or the weakest part of the system. Is there a plan to tackle these people who are, obviously telling the truth on Facebook and all that sort of stuff that we read about, but don't actually understand what on earth the problem is? What is the plan to catch these people in some way, shape or form?
I don't think we're qualified to talk about civil liberties here, Richard. If people don't want it, they don't have to.
We're going to run out of people to vaccine, and we're going to we're going to try and find the people who don't want it, presumably.
Does anyone want to feel that, or?
So we have got a sort of vaccine confidence or vaccine hesitancy campaign, which is being launched today through the Beat COVID North East website, and that's specifically designed to basically to say to people that it's okay to have questions about the vaccine. People will have different issues, and those are all very valid issues that we need to respond to. I think you're absolutely right, Councillor Dodd. There will be people who will just absolutely, not want to have this vaccine for various reasons, and that is, absolutely their decision to do that. But I think at the moment there are, we've got 11,000 people in Northumberland over the age of 50 who haven't had a first vaccine. So I think, there is still, some work that we can do to identify those people who haven't responded, as opposed to those people who have refused to have the vaccine. I think there's always work to do, but obviously we're not going to be able to vaccinate everybody, and at some point we do just need to live with the virus.
Yeah, just wanted to say that in relation to the issues around vaccination, it isn't compulsory, and I understand some of the frustrations around that, but I do know that the government have undertaken a consultation process to look at whether or not for certain professionals vaccination should be part of their employment, but currently that's not an issue. So, but that is something the government are addressing centrally.
So, Councillor Dodd, the answer is nothing. You can't make people do it. So, anyway, Councillor Bowman.
Thank you, Chair. My question is related to supplies of vaccine. Thank you very much for, in the beginning, when vaccines were released, of getting the organisation up and running so quickly and doing a fantastic job You were a shining light to the whole of England, by the way. And because of that, the government decided to throttle the supplies to the northeast. And unfortunately, that took a bit of a sting out of the programme. But on top of that, you got back on track and you did a fantastic job. And I'm just wondering about supplies now. Are they secure? Do we have any problems in the pipeline? Is it 100% secure? Thank you.
Thank you for those comments. So supply is a changing picture. It is again nationally controlled, so it's very difficult to answer that question. We just get told basically with about 2 weeks' notice what the supply will be in Northumberland, and we adjust that according to the populations through our GP data. You know, we are being assured that there is enough vaccine supply, but the amount that we get on a week-by-week basis does fluctuate. But why that is and the reasons for that, I am unable to answer, I'm afraid.
Just to come back on that, can I ask, is that holding back the service that you are providing to the residents? Is that stopping the residents from getting the vaccines? If you got more vaccines, would you do more? Or if you got less, will people get less vaccines?
Gosh, very difficult questions to answer. I think we're following the cohorts. We've always achieved the deadlines that we've been set, and I think that's where the vaccine's been controlled, because we're not seeing the whole of the data that is being controlled nationally. So they are trying very hard, I think, to move everybody at the same pace so that not one area is going faster than anywhere else. So that it's probably quite a complicated equation of distributing vaccine to populations and managing the data is probably some. So we've always managed to get the vaccines done at the right time. Is all I can probably say to that, really. I mean, I think the GPs will be very keen to get it done, but we've had to do it in a very controlled way, doing age group after age group, just to make sure that we get the most vulnerable people vaccinated first.
Okay, Councillor Hill, and then the gentleman in the far corner, and then Councillor Hunter.
Thank you, Chair. And it was good to hear you upholding Liberal principles there. Yeah, my question to Liz, I know you can't predict the future, but there is a concern now with what happened yesterday, the announcement yesterday, that the public is at a tipping point in terms of its patience with restrictions and lockdown. You know, if you go back to March 2020, we didn't know what biblical level crisis we were facing, so people were quite acceptant of lockdown. Then the feeling that the NHS were going to be overwhelmed. Then we have to get the vaccines rolled out. But is there conversations going on within health and government circles? Is there a danger that with the new variants we could see a variant and not just a stop but a reversal of the easing of restrictions? And if so, is there further thought? Because I think that if that was to happen, the public will say, and I think you made the point, that you've got to get to the point where you can have to live with it. So is there a danger there could be a variant which will reverse where we're at in terms of easing restrictions and even go back to lockdown?
Thank you. So, I mean, I think the whole point of pushing back the move into step 4 and pushing forward on vaccination is so that we get to a point where the pool of people who haven't been vaccinated and certainly haven't had that second dose is as small as possible, because the emergence of new variants is going to appear in those people who haven't been vaccinated. So that's why there's this push both to, I mean, it's basically a sort of race between getting people vaccinated and stopping the variant from transmitting even more than it has at the moment. So we're pushing ahead with the vaccination programme, pulling forward the second dose from 12 weeks to 8 weeks in people over the age of 40, so that those people are fully vaccinated. And in that 4 weeks, by not moving into step 4, we are preventing transmission from increasing more than it would have done had we moved into step 4. So it's always a bit of a balance. I mean, certainly the message from the government yesterday was that, that there was no suggestion that we were going to be going back at any point, but it is dependent on pushing on with the vaccination programme.
One thing that you mentioned, the people that aren't vaccinated, there are people vaccinated, 1 or 2, that are catching COVID still.
Yes, there are, because no vaccine is 100% effective. So there will always be people, and actually particularly older people, their sort of immune system and their reaction to vaccines is often not as great as it would have been when they were younger. So there will always be people who can't be vaccinated. There will be people who don't want to have the vaccine, and there will be people who have been vaccinated but who don't respond as well as we would like. So there will be people who, despite having the vaccine, will then go on to get COVID, and actually we've seen that already.
Hello, just a quick question about testing. We looked at the map earlier on with the new Delta variant sort of rising in Northumberland. Is there mass testing going on in that area that was orange? I couldn't see what area it was from over here, but there seems to be quite a spike there. Is there mass testing going on like we've seen in North Tyneside recently?
So we're not yet in the position that North Tyneside is in, but we are at the moment managing, or have been managing over the last week or so, some outbreaks in educational settings, and we have put in additional testing for specific cohorts of students on the basis of that outbreak. But no, we're not at the moment doing the surge testing that North Tyneside are doing.
Thank you, Chair. The 8 weeks calling back, reducing it from 12 to 8. I know you're still saying you're meeting the targets, but that surely has put a bit of pressure on to reduce down to the younger ones. And also students, are you hoping that by September that the students could have their second dose? Because if they're going to university, that's again moving about countries and that, and it's sounding as if the younger generations is maybe more susceptible to picking this virus up. And again, it's looking at the sporting events that are happening at the minute with the football, and other ones they're talking about Wimbledon and that, where they're expecting big crowds. So, that could end up with other spikes coming out.
So we're currently doing remind me, Liz, we're doing the 24, 23 and 24-year-olds as our current cohort. So we haven't gone below that as yet, unless people had were clinically extremely vulnerable or one of the other risk groups. So that's where we are vaccinating, and we're really having to just follow the national programme for that as we go down. So that's where we are. And I think with all the sporting events, they're using a lot of testing, aren't they, for a solution to that, as opposed to using the vaccine. And we'll just have to keep following the cohorts as we have done all the way along, really.
We now move on to 9, which is Newcastle Hospital NHS Foundation Trust Quality Accounts. And so if you could identify yourselves as you start and speak, that would be very helpful to us all. And I'll wave at you from so far away. Okay, thank you.
Thank you. Good morning, and thank you for the invite. My name's Samantha Rutherford. I'm Head of Quality Assurance and Clinical Effectiveness at Newcastle Hospitals. My colleagues Margaret and Cheryl are going to share this presentation with us as we go along the slides. So just as a bit of an introduction, so yes, thank you for the invitation to discuss our priorities of 2021 and our plans for next year's for 21-22. Obviously, this is a regular and routine annual event to share our trust priorities with you all that form the quality account. As you know, last year has been anything but routine. And over the past year, our focus has been very much on caring for patients locally and nationally with COVID. Last year's quality account also contained a section on COVID entitled Restart, Reset and Recovery. It's well over a year since the RVI received the first UK patients with COVID, and this experience allowed us the opportunity to develop our internal processes and systems in advance of the potential for the overwhelming numbers of patients that we were about to receive. During the spring, we saw fewer cases of COVID and positive patients within our area, but obviously down south were suffering from multiple admissions into their organisations. But what it gave Newcastle hospitals was time to very much prepare and learn from the lessons that were learned from down south. In March 2020, with the global health crisis being declared, we reduced our trust activity by 50% and limited that only to urgent and emergency surgery. There was a continued focus on COVID for the period of reprieve through the summer, and that's when we began our work on Restart, Reset and Recovery, which Margaret's going to talk to you about now.
Hi, thank you for letting me talk today. And I thought it would be really useful to share our road to recovery over the last year. March 2020 seems like a very long time ago, about 15 months. So very shortly after lockdown in March last year, around April, the beginning of May, we realised that we were going to have to undertake a huge amount of work to not only recover but to reset and restart and do things slightly differently. So we set a recovery programme which we called Restart, Reset and Recover. The restart was about making sure that actually we made sure that all of the urgent patients, all of our cancer patients who needed access to care quickly, weren't impinged. And we also wanted to make sure that patients actually felt confident enough to come back to hospital, to be referred in, to attend the GP, to get a secondary care referral where that was necessary, especially when we're talking about cancer and patients with renal failure. So that happened over a period of about a month to 6 weeks. Once we got that underway, we then set to think about how we reset and how we deliver care differently during this time. So we split that up into 3 different areas. One was outpatients, the other one was elective care, and the other one was diagnostics. From an outpatient point of view, we very quickly set up different ways of accessing outpatient care, so virtual appointments, telephone, video. Also, other examples were in ophthalmology, where we were doing imaging-only clinics, so patients could come in, be imaged and go home straight away, and the consultant would then review their images remotely via the computer program, which is a great success and is coming into its own this year, which I'll describe a little bit later on. From the other point, from the rest of outpatients, obviously with social distance and other IPC guidelines and regulations, we were, at the very beginning, around about 60% of our activity. So certainly the types of specialties that we provide for Northumberland in particular, which includes ophthalmology and dermatology, the high throughput areas where there are lots of AGP, which is aerosol generating procedures, where we have to be extremely careful what we're doing in terms of that COVID spread. So we set about making sure that we access, the patients access care differently where we could. Patients came either remotely for imaging, as I mentioned before, or had telephone review appointments, so that we kept that footfall through clinic to a minimum. From a surgical transformation point of view, we looked at various different methods of limiting access for patients. So one of our biggest projects was in ophthalmology, where we set about getting a mobile theatre, which is at the old general site, which we now call CAV. So we've got 3 theatres out there, which has increased our capacity by, hopefully, we're going to do 4,000 more patients in a 12-month period to try and clear that waiting list. So that theatre is purpose-built. It's improved our pathway. Now, before COVID hit, we were trying to work out a way of improving our efficiency and the patient experience for those ophthalmology patients, which included a quicker pathway, a clear route through the procedure and out of the other end. So basically, the patients now arrive at the new theatres, are assessed, put in a chair, which actually turns into a trolley, and they're wheeled through into the theatres. That trolley then goes back into being a chair, and the patient's relative comes to the back door and picks the patient up, and out they go. So from a situation where we had patients coming in at 8 o'clock in the morning, staying perhaps 2 or 3 hours, 4 hours, and then travelling back to, you know, as far away as Berwick and out to the west past Hexham. The patients are now in there for approximately half an hour and then go home. They don't go back on themselves. We don't have any mixing of patient cohorts. Relatives can stay outside in the car park that we have there and come and pick the patients up, which has been a fantastic success. That opened up in April, and they're slowly now improving that footfall so that they're increasing the amount of patients that go through there every day, which has been a fantastic success. The other things that we've done in terms of improving access, one of which we're working with Northumbria Trust as well as Newcastle and Gateshead CCG, is fit testing for patients presenting with colorectal cancer. I don't know if you're aware, but over the last 5 to 10 years, with the advent of fit testing and change in referral guidelines, we've been swamped. The NHS has been swamped with patients being referred in for symptoms like blood in poo, change in bowel habit. So with the introduction of fit testing, we're able to now triage these patients, do a fit test in primary care, and then triage these patients when we know the result of that fit test into the right care pathway, for want of a better word. MSU Trauma Service, at the beginning of the COVID pandemic, we had to shut a lot of services down or reduce them significantly. One of those was the elective joint replacement programme, and also to enable us to maintain our trauma access. We are also the major trauma centre for the region, which obviously is it's important that we maintain access for all of those patients. So basically, we cleared a space at the edge of our ED department so that we could have the trauma consultant in ED 12 hours a day to ensure that patients who arrived, we could send straight through to that area. The patient would be processed, triaged and sent directly up to the ward. And that greatly improved that footfall through ED. One of the other success stories of the recovery process was the spinal injection pathway. And I don't know how much you guys know out there, but there are lots of patients waiting for spinal injections, both across neuro and MSK. This procedure was traditionally done in a theatre environment. Obviously, lots and lots of resource is involved in getting the patient in, admitted, processed and out through the other end of that pathway. These procedures are now done in a procedure room, and they're done as a day case with minimal, and it's reduced the waiting list exponentially. So access for those patients is greatly improved, and was made possible due to the changes during COVID. One of the other great success stories was the outpatient delivery hub for medicines. Patients who were seen as telephone or virtual appointments obviously sometimes had to have their prescriptions delivered to home rather than picking them up in the hospital. Even if the patients did arrive in hospital, what we didn't want was a big queue at the pharmacy department downstairs. So we also had access for those patients who we needed to get in and out and through the pathway. That's been another great story of success. We are paring that back so that it's only patients who have telephone appointments or virtual appointments where we deliver prescriptions, but we will be continuing this post-pandemic. In terms of technological improvements, in dermatology, not only are we doing virtual appointments with with images from GPs. We've also got an app that one of our consultants developed a number of years ago called My Skin Selfie, where the patients can download an app onto their smartphone and be able to take an image and send it in through for the consultant to see, not only it on referral, but to monitor it on an ongoing basis. And I think that's all from me. Thank you very much.
Thank you for inviting me along today. I'm Cheryl Teasdale. I'm a senior nurse at Newcastle Hospitals for Clinical Standards and Quality Improvement. So priority one for last year was reducing infection, which is MSSAs and E. coli infection, bacteremias. In terms of C. difficile infection, we had 111 last year. We had no formal objective to meet last year, so we used the previous year's trajectory of 113. It's anticipated that there's no longer the financial penalty that we used to have, and therefore there's no formal appeals process at the moment, and nor will that continue. In terms of MRSA bacteremias, we had one case, unfortunately, in April last year. We've now been 13 months free from that. MSSAs, we've monitored them. We've now started, well, in the last few years, we were using antiseptic washers to try and prevent patients from getting infection, and also improve our procedures and insertion and care around devices with aseptic non-touch technique, ensuring all our staff are trained and they have regular updates on that. 2020 to 2021, the NHS contract now includes community onset healthcare associated infections. So that's any patients that has had an overnight stay with us in the last 4 weeks will now be attributed to the trust. So due to this this change in guidance, we've set an internal trajectory of a 10% reduction. And we have unfortunately not met that. We're slightly over by 12 cases, and we'll continue to work on that this year. In terms of E. coli bacteremia, due to the changes, as I've said, with the MSSA and the cohorts and the increases overall, we again set a 10% reduction rate, which we're over by 1. So we're at 9.3% reduction we achieved in the last year, which I think is a huge achievement in that the patients that we have been receiving are certainly of a higher acuity, more care is required. Our cancer services has been 100% occupancy throughout COVID, and now, you know, the patients that we have got in are requiring a lot of care, and if we've got lines and things in place, a lot of invasive devices, which do increase the risk of infection. Klebsiella infection, we've had 129 cases, which again, it exceeds our 10% reduction by 6 cases. And Pseudomonas bacteremias, we had 45. Again, that's exceeded our 10% reduction just by 1 case, though. All of our cases are reported to Public Health England and the Trust Board on a bi-monthly basis. And we have work streams which are overseen by our Director of Infection and Prevention Control, which is on behalf of the Infection Control Committee. Mandatory reporting, however, formal MDT-led root cause analysis have been suspended during COVID. Obviously, we've needed to look at any COVID infections which have been attributed to the Trust, and we've absolutely focused on that. So therefore, root cause analysis of MSSA bacteremias and E. coli have been suspended. However, we have done a local review of that and looked into cases and any learning that we could find. We have restarted that work now. In terms of antimicrobial stewardship, that is the reduction of antibiotic use within the Trust, and that's across the community trust as well. That was a sequin that was introduced last year, however, has been suspended. we are hoping that that will restart this year and will refocus our work and moving forward to reduce the use of antibiotics. It's been difficult during COVID, as you can imagine. In terms of sepsis, we did have an alert system put on our electronic patient record last year, which alerted nurse and staff to what they needed to do, and medical staff as well, which just give that safety net to ensure that we were escalating appropriately. That was due to a technical glitch that has been suspended, and has just restarted this week with excellent results actually. And we're really focused on reducing incidence of sepsis within our trust, and that training is now in the next year going to become mandatory for all members of staff. Next slide, please. Priority 2 was reducing our inpatient pressure ulcers of category 2, 3 and 4 and deep tissue injuries. We have performed a lot of quality improvement work over the last year, which has included ensuring that our results, any incidents are absolutely reported at ward level and escalated up to board, but we've been able to target those areas of high incidence by doing some training with staff and also finding ways in which they can reduce incidents within their wards and departments. And that's been very, very successful. In one case in particular is care the elderly medicine, where we do have a high rate of pressure ulcers. We have had a significant reduction in serious incidents by 43% within that area, and we're continuing that across the trust. The other success has been the RCA process, which used to take 2 to 3 months to complete. It is quite a significant undertaking, and we're really reviewing, performing an in-depth inquiry into that. We've looked at the RCA documentation and changed that, and had more clinical involvement, and it has been, it's actually a bigger document than what it was. However, what it does highlight is all of the care that the patients received, rather than just focusing upon the negative and seeing what good practice we can pull out of that as well, but then creating that learning opportunity for staff, which has been received very well, and has led to a reduction. What we have seen, unfortunately, which we've seen across the UK, is an increase in pressure ulcers attained in ITU. This is due to the positioning of the patient. We've had a lot of proning injuries on faces. However, when we're comparing to the other trusts within the Shelford group, we have done particularly well actually, and it was, as Sam said earlier, it was that they'd sort of went through before we did, so we were able to get some good practice into place. So therefore it has been where we've seen them increases is within intensive care, and also within wards. We've had to convert a lot of surgical wards to take medical capacity, and also COVID. So then patients were significantly of higher acuity and required more care. And we've just had to work with them teams from a tissue viability point of view to help reduce incidence. Thank you.
Sorry, microphone on. Management of abnormal results. As a trust, we always said that this would be a long-term solution for our management of results. Previously, test results were recorded on paper, which then could be clipped to the front of patients' medical records. This method encountered a number of issues, as you can imagine, such as the results being lost or clipped to the wrong patient's medical records. Since the process has been moved to an electronic system, it has provided a fail-safe and made it easier for us to undertake audits and ensure the results are reviewed and endorsed timely by clinicians. Over the last 2 years, we have invested time to ensure there is a closed-loop system, from the point of tests being requested electronically to the report being received and reported to by the appropriate clinician. A design authority was set up to overcome some system functionality glitches in the first stages of the system being sent up when it went live. The design authority is also there to ensure that we have appropriate escalation processes to enable patients to receive the necessary care even if their named clinician is not available. Next slide, please. So priority 4, closing the loop. Within Newcastle Hospitals, we have an incident reporting system called Datex, and that gives staff the opportunity to obviously report any incidents related to pressure ulcers, falls, near misses, that sort of thing, and it's very embedded in practice. So this priority again involves an electronic system to ensure that recommendations from any external accreditation visits or internal investigations, inspections and reviews are all recorded and monitored in one place. This then allows the clinical leads and the heads of department to easily monitor and record the implementation of those recommendations with appropriate prioritisation and escalation. We spent over 18 months as an organisation trying to find a commercial solution, but they were quite often not fit for purpose or, in true style, very unaffordable. The Trust then employed an expert in Datex, which we were delighted to do, and the newest version of Datex was then procured. This closed loop system was called the SAMS system, so Systems, Action, Monitoring and Management. A couple of directorates piloted this, and that went very well after they received the training, and they found it very valuable that all this information was in one place. However, with COVID and lots of things occurring within the organisation, this particular system was deferred because there was also a further upgrade to Datex as well. So we're now going through the stages of this ongoing upgrade, and this will include an action plan management module, along with incident investigations. We can also see our complaints there, claims, and obviously the risk register for each directorate. So that's very much giving us an absolute closed loop system. Next slide, please. So priority 5, enhancing capability and quality improvement. So this work was identified in order to improve clinical quality and outcomes and to allow us to focus efforts on continuous quality improvement as a way to promote staff development and involve frontline staff in service and quality improvement. There is a need to invest in the development and the skills of the frontline staff so they can identify and take ownership of quality improvement very much at a local level. Therefore, we're very excited that we've joined partnership with the Institute of Health Improvement, the IHI, and invested in a major transformation of how we can improve quality of care for our patients within the organisation. We will work together over the next 2 years with the ambition of providing all of our staff with a basic awareness of quality initiatives, give them the tools and techniques and access to resources to support and a supportive infrastructure. Within our organisation, we have Newcastle Improvement, and this will form the single point of access for all of the staff and is now the faculty that will continue to deliver ongoing training and will learn how to deliver the IHI training programmes. Next slide, please. Priority 6 is our Treat as One. This priority is about improving access and equity for patients in the acute healthcare environments with mental health conditions. The National Confidential Inquiry into Patient Outcomes and Deaths, known as NCPOD, provided a report with key recommendations. Our aim is to use these recommendations to guide a coordinated review of current practices and processes within the Trust and working alongside CNTW Mental Health Trust. We now have improved communication with CNTW. We attend quarterly meetings and coordinate actions together and work very collaboratively together on a number of projects. CNTW is now supporting us with training and development of our staff in recognising and how we can care and support and manage patients with mental health conditions in the acute setting. The original NCPOD report was written with adults in mind. There is now a very similar report for young adults and children. This will also be a focus for us in our forthcoming year. As we know from COVID, it's had a huge impact on our young people and children, and we're regularly seeing that now in hospital, people attending with acute anxiety state. Next slide, please.
That's me. Priority 7 is about improving the care of our learning disabilities patients and ensuring that we've got good access and improve their health outcomes, which has been highlighted as an issue for many years now. We have had some changes within the team in that we've increased our team. We've got a part-time band 7. We've now employed a full-time band 7 and also a band 6 now who's brought a paediatric qualification with her. She's got a vast amount of experience within learning disabilities. We continue to prioritise work streams in relation to any national expectations, and also we've got steering groups who report to the Safeguarding Committee as well. We provide a framework from the National Diamond Standards, which we ensure that we have that in place for our acute and elective admissions who have a learning disability. We also have an electronic training package for our staff, which is now being implemented across the trust. And we're now part of the Learning Disabilities Improvement Standards survey again this year, which includes self-assessment against standards and patient and carer feedback. And this work will be ongoing with young people transitioning from adult to adult services, and further audit work will continue to improve standards across the trust for patients with learning disabilities. Next slide, please.
Okay, so finally moving on to our the chosen priorities that we will invest additional resource and effort into commissioners, our trust board and to the public in next year's quality account. So we are held to account naturally and correct.
Yeah, we'll continue to try and reduce hospital-acquired infection rates, in particular with the COVID-19 healthcare onset as well, and also in relation to sepsis, improving standards and ensuring staff are aware, and we utilise the alert, and we'll be monitoring that very, very closely. Antimicrobial stewardship with the Sequin will be working towards reducing our use of antibiotics within the trust. Our new pressure ulcer reduction is a community-based one within the Newcastle district nursing teams. We do have quite low levels of acquired pressure ulcers in the community. However, there is room for improvement in that patients receiving equipment being assessed more regularly, and also because we have had quite a high turnover of community staff recently, it's just ensuring them staff are skilled.
And from a clinical effectiveness point of view, obviously I've talked about our excitement around the QI project and bringing QI to our, all of our staff so they can really recognise projects that they want to do and that will make a difference in their workplace. We've also added in there maternity early warning score. So as you may know, nationally it's been very much embedded in adult practice that we have a system by which we can track a patient who's potentially deteriorating and escalate their care appropriately. Maternity services haven't had an electronic version of this, so we've currently got a paper version and we're working towards that. So that's about recognising patients who are prenatal, postnatal, up to about 3 months postnatal, and if they come into hospital with another condition that we recognise that they have been through this maternal event, and then we need to watch out for different potential deteriorations. Patient experience, again, we've all talked about wanting to assist our patients who have learning difficulties, make it feel easier for them to come into hospital, feel supported, and lots of work will be underway. And then again to mention NCPOD, very much around our vision about recognising the gap for young adults and children around managing their mental health when they're in the acute setting. Thank you. Any questions?
Sorry, Councillor Hill.
Thank you. I've got 2 short questions. Can I raise them both? Because they're quite short yet. Thank you. So there's 2 things that have come up in the report that particularly interested me. Page 39, your page 7, mentioning levels of activity fell to 20 to 30% of the pre-COVID activity levels. It's a funny way to report 20 to 30%. Do you mean at any one time it was like bounced between 20 and 30% of what you normally would have? And my other question on that is, how does that compare with Is that equivalent to what was happening elsewhere as well?
Yeah, it was. I suppose that was way back in March and April last year. We saw, we had to very quickly, I think the word was used, biblical earlier. So I think right back in March 2020, we didn't know what we were going to expect. The modelling that was done by the universities and nationally with NHS England suggested that we were going to have massive waves coming in. So activity was all but cancer activity, and urgent and emergency activity was cancelled. So we did go down at the very worst to 30% of activity, but that very quickly escalated back up to, when we got to middle of June, July last year, that was up to 80% from an elective care point of view. And by September, from an outpatient point of view, including telephone appointments, we are actually now above 1920 baseline. So we are, at this moment in time, if we fast forward to last week, we were at 108% of outpatient activity in total we're doing now via our other methods of seeing patients as well.
Great.
So, and electives are up. Last week we were over 90% for elective activity.
Great. And my second quick point was on page 67, your 35. It's really good to read things like, being open, duty of candour policy. That is obviously very extremely important. In what ways are staff encouraged to speak out?
I think from a duty of candour point of view, we've got the DATEX system, as I talked about the incident system, and there's a component within the DATEX system, so that follows and urges people to follow duty of candour. I think as an organisation, staff on the front line on the wards are very open and very able and feel that they can approach families and patients and say for example, if there's a pressure also, they would feel absolutely free to go up and say, we're sorry that this has happened, and go through the methods. Cheryl's talked about root cause analysis again, so again it's looking at all of those incidents. We want to empower our staff there at the front line, and we absolutely encourage that, and the senior nursing team within the organisation make that very clear to people. So we want to have this open and honest culture throughout all of the work that we do.
I'll just add to that as well, from a patient perspective and families, we are now, in the last year, we've offered to, sort of have a meeting with them and go, because them reports, we do share them with patients if they choose to. However, sometimes they're a bit wordy and they mightn't understand, so we'll absolutely offer that point of an interview as well. Sorry, an interview, a discussion.
Thank you. Debbie Nugent from Health Watch Northumberland. We've already made our response to your draft account for this year, so I'm just going to reiterate, I think, for the benefit of people who won't have seen that yet, the issues that we raised. We obviously welcomed and thanked you for the service and the services that you've delivered over this last year. The two issues that we raised specifically in our response were about the feedback that we get from people who use services from Northumberland into Newcastle. And certainly we feel that within your draft quality account, we would like to see some more mention about that, especially because obviously some of the key services around audiology and ophthalmology have been quite, there's been quite some concern about some of those. We did a report obviously last year around the audiology services particularly. So I think sometimes with the quality account it would be nice just to see something a bit more about the Northumberland experiences. I think the other point we made as well, and to be fair, this is something we do make across other trusts as well, is the degree of and amount of information given about complaints. You'll have seen the Health Watch England report last year, or just beginning of last year, about the importance and help that the complaints process can give to trusts and the learning that comes from them. And I think, again, we mentioned in our response last year that some more detail about the complaints you'd had and what had happened as a result, I think would just give that bit more confidence to people about complaining and what can happen as a result. But as I said, I think they were the two things that we said, and we thought the priorities for the coming year were we're okay.
Thanks for that. Councillor Hunter?
Yes, thank you, Chair. I know you had to adapt quickly through COVID to change your services last year, and some has worked well. Are you hoping to try and roll that out to other services that can be adapted? And again, as to hopefully going back to face-to-face appointments, if that's what residents require. It's that sort of trying to do the two things, save money one way and save time, as well as supporting staff, but also going back to the ways that some patients may prefer.
Absolutely, we're very, very conscious of the fact that non-face-to-face appointments don't work for everybody. So we're doing we've done patient satisfaction audits with and actually they've come out very well. Most of the patients that we're identifying for telephone and video appointments appreciate it. I think that there are lots of patients around our cohorts. We're not just dealing with, as we're here today, we're not just dealing with Newcastle residents, we're dealing with patients who come from Berwick all the way back up to West, but also our regional patients who are, far away as Whitehaven and down to North Tees. So they've really appreciated the ability to be able to telephone in. But we are also doing some clinical audit work to make sure that patient care doesn't suffer by having a telephone review appointment, and we're making sure that where access is necessary, that we do absolutely do that.
Councillor Bowman?
Thank you, Chair. Just a quick question about the changing times that we're living in. Have you seen an increase in long COVID within your services? Have you adapted to that?
So from a respiratory point of view, we have now got specific long COVID clinics identified with specialist clinicians and nurse specialists delivering those services. So yes, we have. Not as much as we expected, I don't think is the word on the, but it's very difficult at this point in time. I mean, public health would probably be able to offer a more in-depth answer to that one, but we haven't as yet seen the true impact of long COVID, I would suggest. But yes, we have got services, people are accessing them. And we have multiple research studies where patients who have had COVID have been recruited to and very in-depth review and access, including psychology support, as well as physical help and support. And that's done in conjunction with Newcastle University.
Can I just thank you for the hard work that you've done over the last year and a half? It's been tremendous to see that the National Health Service stepped up to the mark, and thank you very much.
Thank you.
I just wanted to say this is the first meeting of this overview and scrutiny that I've chaired, and it was a bit challenging getting this. The very first thing I had to read was 3/4 of an inch thick. Obviously, we can't challenge the figures in the report because we haven't got the ability to do that. So we just have to take it as read. What I did find useful was the abbreviations, an explanation of the abbreviations, which Councillor Dodd and I both have trouble with. But I was just wondering, 7 priorities seem a little weird to me. It's 5 or it's 10. I'm just wondering why. Was this a random number or how did you end up with 7?
So what we do with the quality account is very much look at what's happened in the previous year. Sometimes the priorities roll on, like I've described a little bit around continuing with the abnormal results. Obviously, we wanted to do the QI project because that's very important to us as an organisation to make sure. So how we ended up with 7 is literally looking at what incidents we had, what we've done in the last year, what we felt that we needed to grow further on from that point of view. So yes, it might seem a little bit random, and I get that with you, but that is what we felt we could, those 7 priorities, is what we could achieve within the year.
So so once do you identify your priorities and then find the resources to work towards those priorities, or do you have the resources and then decide how many priorities you're going to have?
That's
a difficult question. I think lots of our priorities are related to quality improvements. So very much we have capacity within our huge workforce to pull these priorities together. And we also spoke to staff and spoke to patients and Apex and that sort of stuff to think about what would mean, what things, priorities would mean to them and what they wanted us to achieve as well. So it's a very collaborative approach.
Is it worth, but I mean, some of the priorities will pick themselves. We have to do it because they're so urgent or, you know, are so important in terms of the strategy and vision of the Trust going forward. So I don't think wouldn't pick a priority just because we had the resource available to do it. You know, it's a much more in-depth decision than that, certainly collaborative across.
So in the end, who makes a decision that there's going to be 7 or these are the 7 we're going to do, or this time next year when you come to us, will there be 5?
For the last few years, there have been 7, I have to say, but the Chief Exec ultimately, along with the Medical Director, will sign off the quality account.
Okay. So. The other thing I was just wondering about, there's a whole appendices with blank pages in, because you're waiting for comment from us, apparently, as well as the council, and we've heard the Health Watch people have put theirs in, but it's not here. And it would have been interesting to have seen what these other people have said. So next time, if we could somehow have that before we see this, it would be quite handy.
Yes, I mean, we do work to very tight deadlines, and obviously this hasn't been fully published for next year moving forward. Yes, but I take that on board and we can get that information to you as it comes in.
Okay, thanks for that. Anyone else wish to comment or have a say over this? It appears not, so thank you very much for coming. It's been a pleasure to see you all. It's a bit odd, as you can realise, and I'm sure it's no odder than where you work.
Yeah, thank you very much.
That's no trouble at all. So the next thing on the agenda, if I can just go back to it, is the primary care application working group. It doesn't meet very often, I understand, but it's manned by, or personed by myself and the Vice Chair, Kath Nesbitt. It requires 2 other people. I would prefer myself if at least one of them was a Conservative. I think it's important that there is a, you know, there is a balance. But if I've got 2 volunteers, then that's the way we do it. Councillor Bowman and Councillor Hunter, but I think that might not be the geographical spread, I might think. Sorry, sir, I really apologise that your name escapes me and where you're from also does.
Yeah, Chair, I'm
Well, I know who you are.
I'm
talking about the person.
Hollywood Ward.
I'm talking about the person behind you. I know who you are, Councillor Bowman.
It's Councillor Humphrey from Newsham.
Right. Well, I don't think. Well, my problem. Sorry, my problem with this is that the chair and the vice chair are both from Blythe, so I think pulling somebody else from Blythe would not be an appropriate thing to do on this occasion. I would prefer that it was 2 Tories myself, but if Councillor Hunter, who couldn't be far enough further away from Councillor Nesbitt and I, would volunteer, but then I would really kind of desperately
nominate Councillor Homer.
There we are then.
And then that's the West covered.
Yeah. So are we content with that? I appreciate you volunteering, but you can see what the problem would be. So are we happy with Councillor Homer and Councillor Hunter? We don't have a... Right, that's it. But Les, how am I going to sort that out? Right, tell you what I'm going to do. Because Councillor Homer isn't here, and we don't know what her attitude would be, for the moment I'm going to say Councillor Bowman and Councillor Hunter. And then if we get some problem from the administration about there being lack of Tories, we'll just have to think of another way of doing it. Is that all right, Councillor Dodd? Well, not necessarily. You can come back to it.
I made a nomination.
You did, but you can see, I would prefer, but obviously, commitment-wise, we don't know whether she's going to do it or not. Yes, Councillor.
It's just that it's non-political as primary care. So, it doesn't really matter who's on it. It's about whatever comes up. So it's not political.
Right, so we're going to try it that way first, and if anyone wants to complain, we'll come back to it. Is that okay? Right, excellent. So that's Hunter, Bowman, Reid, Nesbitt. Okay, excellent. So the next thing is Health and Wellbeing work programme. I think Chris is going to talk to us about this for a few moments, hopefully.
Thanks, Chair. The work programmes for members to note, it's a list of the upcoming reports that are coming to this scrutiny committee under their terms of reference. If there's anything members want to add to the work programme, they can approach either myself or Councillor Reid as Chair, and we'll find a way of trying to get that onto the work programme. But at the moment, it's just for members to note.
Okay, so we note that, and approach Chris if there's a burning issue you feel as though we should be talking about, then let's talk about it. Urgent business, I've been notified that there isn't any, which is great. And the next meeting will be on Tuesday, the 6th of July. But note the time is now 1 o'clock because it's more convenient for most of us to be here at 1 rather than at 10. Thank you all very much for attendance, and I look forward to seeing you then. Thank you, and thanks for your forbearance over this because it's just weird.